Welcome everyone. My name is Réka Petra Tóth, and I would like to introduce my PhD topic, which is insights into mechanical ventilation. So prolonged invasive mechanical ventilation can lead to severe lung injuries in 25% of the cases. Automated modes have been developed to reduce the burden of mechanical ventilation. However, their clinical effectiveness is still debated. In this meta-analysis and systematic review, we found that there is a tendency for adaptive modes to shorten the duration of invasive mechanical ventilation by 1 day. We do think that further research is needed in order to, first, to find the best cohort that benefits the most, and second, to improve further the efficacy. I am a PhD student here at Semmelweis University, and I envision a future where everyone has access to advanced medical technology, no matter who they are. And my mission is to improve current medical technology. In order to do so, we launched 2 projects this year. One is a systematic review and meta-analysis comparing conventional modes to adaptive modes, and the second one is a retrospective observational study. So let's start with the first project, comparing the effectiveness and safety of adaptive versus conventional modes in invasively ventilated adult patients. Nearly half of the ICU patients are requiring mechanical ventilation, which is far from having no risks, such as ventilated-associated lung injuries or pneumonia. We could say that the more time a patient spends on mechanical ventilator, the more likely these complications could occur. We are nowadays using manually adjustable ventilators, which means that adjustments only made when the clinician checks the measurements and then set the ventilator accordingly, which could elongate the duration of ventilation since it cannot follow the patient's needs in real time. However, there are new closed-loop ventilation modes that are available, which can tailor the ventilator to the patient's needs in real time, either by analyzing it between 2 breaths, or within 1 breath. Even though they seem to work better in real life, we do not have enough evidence to say that, so we need to further investigate it. So our question was, are adaptive modes more effective and safer than conventional modes? We used the PICO framework. We investigated invasively ventilated adult patients. We compared adaptive modes to conventional modes, and our primary outcome was duration of ventilation. So here you can see we started our journey with 13,000 articles, and at the end of the selection process, we ended up with 48 eligible articles for data extraction. Here's our progress throughout the year. Now we are at the stage of manuscript writing. We would like to finish the manuscript writing at the end of September. For easier understanding of my outcomes and my results, I would like to introduce them. So here's a nice picture to describe them. Duration of ventilation starts from intubation and ends with the cessation of all ventilatory support. However, duration of invasive ventilation ends with the successful extubation. We had 2 patient populations. One was general ICU medical patients, and the other one was postoperative patients. So we have 2 similar outcomes. Both of them starts at the readiness of weaning and ends with successful extubation. Duration of weanings used for general ICU patients, and the extubation time for postoperative patients. Now I would like to introduce you our results. This is our main outcome, primary outcome, which is total duration of ventilation. As I mentioned, it is an important outcome since the less time the patient spends on a mechanical ventilator, the less likely these complications will occur. It ranges between 3 days to 7 days, which means even 1 day reduction could be quite beneficial for the patient and is clinically relevant. We use subgroup analysis to have a better understanding of different modes and how they affect patients' outcomes. So we find that in the adaptive support ventilation group, there was a reduction of 1.5 days, and it was clinically and mathematically significant. However, when we checked the pooled estimate, we ended up 1 day reduction, but it was mathematically not significant. Our next outcome was total duration of invasive ventilation, which is just as important as the total duration of mechanical ventilation. In this picture, we could say that ESV did not perform as good as the previous outcome. However, our pooled estimate was -16 hours and it was almost almost statistically significant. It just only shows us a tendency for shortening the duration of ventilation. Let me introduce you another outcome, which is ventilator-free days. Basically, it's defined as all the days that the patient spent without mechanical ventilatory support and being alive. So it's a combination of total duration of ventilation and mortality. It's actually a nice factor or a nice outcome showing how good our patient could recover from respiratory failure. We used a subgroup analysis based on etiology, and we found that even though we didn't have a pooled estimate that was statistically significant, we found that if we don't include, or we have a subgroup that don't include strictly COPD patient studies, we ended up with a statistically significant and clinically relevant studies, which signals us importance of investigating which patient population could be benefit the most, and it should be investigated further in future research. Let me show you our other results. So it is the extubation time and duration of weaning. However, there were no statistical significance here, and the same could be said about weaning success and extubation success as well. Our study and research has its own strengths. We used rigorous methodology, we had high number of studies, we had a clinically relevant question, and we had a transparent reporting of the outcomes. However, we had our own limitations, such as because the nature of the mechanical ventilator, it cannot be blinded, thus it could elevate the risk of bias. We worked with the high heterogeneity due to the patient population, and also the outcome reporting varied between studies. Our main conclusion was that there is a tendency for a shorter duration of ventilation, and also that adaptive modes are non-inferior to conventional modes. We had an implication for practice and research as well. For practice, that it could be a good asset in general ICU patient management, and our implication for future research is that we need to find the best cohort, and also we should improve this technology further. So let me talk about my next project, which is model-based optimization of mechanical ventilation, which would be a retrospective observational study. So as I mentioned, we are ventilating a huge number of patients with a high rate of complications, and we do know that by optimizing ventilator parameters, we can improve outcomes. Our ventilators already do that by using simplified lung models, which is a mathematical model, and we could also specify these outcomes, specify these parameters by using special maneuvers, although these maneuvers do not have standard evaluation, and it's totally up to the clinician's expertise. So we need a more sophisticated mathematical model for a given patient population in order to optimize further the outcomes. And our aim is to create that mathematical model and first step, check its accuracy. So our research question is, how accurately can our mathematical model estimate the pressure-volume flow relation in mechanical ventilated patients? And we hypothesize that it actually can. So let me sum up. At my first project, we wanted to check how effective it's the newest mode that we could get, or we could see in the market. And in the second project, we would like to offer another option to further improvement or further, yes. So let me close my presentation with a quote that reminds me how important it is to find a great question in order to understand our results. The ultimate answer to life, the universe, and everything is 42. Thank you for your nice, kind attention.
You mentioned COPD patients,
yes,
who did not respond so well to this adaptive mechanical ventilation. Was there any reason to look at, like, whether it's more smoking associated problem, or is it also valid for emphysemic people? Maybe there was no data, but it would be an interesting thing, like whether we could influence this patient group also via smoking.
Yes, that's an interesting question. So it's a bit misleading, because this was an idea to check the etiology because of our, knowledge about the etiological factor, and maybe we had some knowledge about that ASV could work, has a tendency to work better with the COPD patients. However, we have little studies to check that. As you can see, we had only 2 COPD studies, maybe one more that didn't actually use the ventilator-free days as an outcome. So yes, it's probably there's a factor in that as well. Thank you very much.
And you suggested that this adaptive type of device would be much better. So the, I would say, ICUs with personnel problems, like low-level personnel, would still benefit. Do you think that with increasing study numbers or increasing patient numbers, eventually your data could become or would become statistically also significant?
So for these outcomes and for this patient population, like the hand-picked patient population, and it was said in several randomized controlled trials, they do not believe that would happen. So there were several pilot studies that actually stopped because they found that there were no reason to continue that. But most of the time they mentioned that there are other patient populations, such as difficult to wean patients, that would be more interested or to check which one. Also, the different modes have different, I would say, perks. So they could be useful for different patients because of the mathematical model behind it and the reasons behind it.